Start?
The way. So, good evening, everyone, and we welcome you to this ninth week of MOA Masterclass. The theme for this month is orthopedic infections, and today we have with us Dr. Aditya Menon, who has worked with Dr. Agashe for a long time and has a very unique perspective about orthopedic infections. So, he works at PD Hinduja Medical College, Hospital and Medical Research Center. He is Secretary of Infection Section of APOA and Country Representative for India for European Bone and Joint Infection Society. So we welcome you, Aditya, and look forward to your talk on early surgical site infection, retain or remove the implant. Welcome, Aditya.
Thank you. Thank you, Dr. Ashok. Respected seniors, colleagues, and friends, a warm welcome to this next session on MOA Masterclass series. At the outset, I would like to thank Maharashtra Orthopaedic Association for giving me an opportunity to be a part of the series of the presidential theme initiated by Dr. Aditya sir. My talk today would be focusing specifically on early surgical site infections, where we are dealing with an implant which is present inside. Now, these cases present a challenging scenario to all orthopedic surgeons. What I would attempt through my talk is give a protocol on how these cases can be tackled in a systematic manner. All the cases that I will be highlighting today have been managed by a multidisciplinary bone infection team at Hinduja Hospital, of which I am a part. The team is headed by Dr. Agashe sir, who's an orthopedic surgeon. It also comprises of infectious disease specialists, microbiologists, plastic surgeons, radiologists, and pathologists. Now, when I see these kind of situations in my OPD, where a fracture has been internally fixed either with a plate or a nail or wires, with a leaking wound or an exposed bone, an exposed implant, discharging sinus presenting early, it's a big challenge. It's a nightmare for the primary surgeon or the referred surgeon. The challenge lies in handling the patient, in handling the fracture, in handling the wound. The first thought that comes to my mind when I see such a situation is whether I can just give empirical antibiotics and tide over this. In that way, I can at least retain the implant because I've done a debridement. Now, in spite of doing all of that, the question that arises is, will any of this suffice? Will the fracture go on and heal with or without debridement based on empirical antibiotic, or if we get a culture? Or will the bug ultimately be the bone and the biology? And this early infection, will it transform into a full-blown infected non-union, which is a very, very challenging scenario. When we go through literature on how we can manage these cases, there are multiple articles on this, but it ultimately boils down to four very, very crucial factors. The first of it is the stability of the fixation. How stable is the construct? The second is the duration of infection. How long has this infection been present inside the patient? The third is the resistance pattern of the bacteria that we are dealing with, or is it a fungi? And the fourth is the soft tissue status, whether the implant can be covered or no amount of reconstructive surgery will be able to cover the implant. What we know as orthopedic surgeons is these x-rays where screws are backing out, plates have come off the bone, or wires are backing out. These are unstable fixation. There is no doubt in this. These implants cannot be retained at all. These implants must come out. The second is a delayed presentation. Where a patient comes with a discharging sinus for many months or years. Can we think of retaining the implant in that case? The answer is no. The reason being, by then, over months or years, the bacteria form a biofilm, not just above the plate, but even under the plate, as is seen in this case, where he had a discharging sinus for close to 2 years. You can see the biofilm is there right at the fracture site. Until that biofilm comes out, the bone is not going to heal. The biology is not going to be conducive enough for the fracture to consolidate. So in this case, the implant has to come out, or in similar cases with long-standing infections, implant retention has no place. Third is the organism that we deal with. Now, when we have multi-drug resistant organism, which we are seeing in increasing numbers on a day-to-day basis, especially drug-resistant gram-negative bacteria, implant retention again becomes a big challenge because we are left with minimal antibiotics. So in most of these cases, implants must come out. And the fourth and the most crucial factor is the soft tissue cover, especially in the distal tibia or the proximal tibia, where the soft tissue envelope anyway is not good. After debridement, if we do not have the backup of a plastic surgeon, we cannot leave an implant exposed or put a negative pressure wound therapy on the implant and hope that the fracture consolidates. The fracture and the implant must be covered as soon as possible. So if that is not possible in our scenario for various reasons, then the implant must come out. And we have to think of other options like external fixators. So the question then arises is, when can we retain the implant? We've seen when we should not retain the implant. So when can we retain the implant? To highlight when we can retain the implant, I'll go through this case scenario who was a 47-year-old female who presented 4 weeks after the surgery done elsewhere, had a surgical site infection on the medial aspect of the ankle. This was the X-ray presentation. The patient had a trimalleolar fracture with fixation of the medial malleolus with tension band wiring and a long wire in the fibula. The posterior malleolus was not addressed. We had fixed the medial with a tension band wiring and lateral with a long wire, not opening the fracture site. Unfortunately, the patient developed a discharging sinus along the medial incision. The surgeon took a swab in the OPD, which grew methicillin-resistant Staphylococcus aureus. Based on the sensitivity, the patient was started on linezolid and clindamycin orally, and the sinus was stapled in the OPD. Unfortunately, the sinus persisted. The patient presented to us at around 4 weeks from the primary surgery with a normal WBC count. The CRP was 15, which was borderline. ESR was raised at 60. The challenges here were it was a subcutaneous implant with an early infection and a resistant bacteria, the MRSA. So the question that we were faced with is, can we retain this implant? There are two very, very important guidelines laid down in literature a decade apart by the same authors as far as early surgical site infection with an implant is concerned. What these authors say is that there are 4 important things that we need to analyze. One is the duration of infection. The infection must be within 2 to 4 weeks of the primary surgery, or if it is a late infection, it should be an acute infection with symptoms lasting only 3 to 4 weeks. The second is the stability of the fixation. The implant and the construct must be stable and the reduction must be acceptable. The third is the soft tissue. The surgeon, either himself or with the help of a plastic surgeon, must be able to cover the implant either immediately or early within the first 48 to 72 hours. And the fourth is the bacteria should not be a difficult to treat bug. Now, what is a difficult to treat bug? A difficult to treat bug is one which does not have any oral options available. So if it is a staphylococcus which is resistant to rifampicin or clindamycin, then it's a difficult to treat bug. If it's a gram-negative bacteria resistant to ciprofloxacin or other fluoroquinolones, then again it becomes a difficult to treat bug. Fungi, as a norm, are difficult to treat. So if all these criteria are met, that is, the infection is early, the construct is stable, early soft tissue cover is possible, and an oral antibiotic is available for our use, then and only then can the implant be retained. These are the guidelines laid by in these 2 papers, which will help us manage this case. So, considering these guidelines, we went back to our case. The duration of infection was 4 weeks, which was just about correct. When we explored the wound, we excised the previous scar, and we found that the fracture was stable. The wires were not loose. It was a good construct. It was stable. We left it in situ. When we sent the deep samples, they again grew methicillin-resistant Staphylococcus aureus, but oral antibiotic options were available. So the infectious disease specialist then started the patient on intravenous teicoplanin for the first 2 weeks, and then shifted to oral clindamycin for the next 6 weeks. Total duration of 6 weeks was the antibiotics were given for a total of 6 weeks. As far as the soft tissue cover was concerned, after our primary debridement, where we excised the previous scar, all the infected necrotic tissue around the fracture site, we decided to use negative pressure wound therapy for the first 3 to 4 days, and then redebrided and closed the wound on day 5, and we could achieve a good soft tissue cover. We observed the patient radiologically, clinically, serologically, and we could retain this subcutaneous implant, and the patient had an infection-free follow-up at 12 months from the primary surgery with good ankle range of movement. This case is similar to the first case. Again, it was a biomalleolar fixation with infected tissue along the medial aspect. We debrided. The fixation was stable. The culture grew a pan-susceptible pseudomonas. Patient was started on oral ciprofloxacin, continued for 6 weeks by the infectious disease specialist. The plastic surgeon did a local rotation flap. The implant was retained, and the fracture went on to consolidate, and the patient had a 15-month infection remission follow-up. Now, this third case was one of our own cases, which becomes always challenging when it is your own case, because managing such cases becomes very, very difficult. So this was a comminuted intertrochanteric fracture, which we fixed with a long cephalomedullary nail. Unfortunately, the patient developed a deep collection within the first week. Ultrasound showed it to be a 40 cc collection around the just a hematoma and it would subside. Unfortunately, that was not the case. The hematoma recurred, the swelling recurred, there was local warmth. We decided to go in. We did the radical debridement, excised the previous scar. You can see this lower part of the greater trochanter was a loose piece of bone there, which we excised. All the necrotic tissue was removed. And then we assessed this patient. The duration was an early infection. Sorry, I'll repeat that again. The ultrasound showed a deep collection of around 40 cc. Which we aspirated in the operation theatre. Unfortunately, the infection did not subside. The collection recurred. The patient had local warmth, tenderness, redness. We decided to then explore the patient. We excised the previous scar, removed all the necrotic tissue. There was a loose piece of greater trochanter along the lateral wall, which we had to excise. The fixation was stable intraoperatively. There was no movement at the fracture site. We could achieve primary closure because generally the thigh tissue was very lax, and even after a excision of the previous scar, we could close the wound primarily. So 3 out of the 4 criteria were met. Now the question was, how could this be a stable fracture in spite of a lateral wall combination? What we had achieved in the primary surgery is what helped us retain the implant. This lesser trochanter, which was high riding, had been pulled down and wedged into the medial wall. This is what gave us medial wall continuity and stability at the fracture site. The culture grew a methicillin-resistant Staphylococcus epidermidis. Now, this is important to note because Staph epidermidis is a coagulase-negative Staphylococcus aureus, which is present on the skin. It's a normal skin commensal. What could have happened is, during our aspiration, we may have introduced this bacteria into the deeper tissue. But now that this bacteria grew in the deep tissue, it could not be ignored. It was not just a commensal, it was the cause of infection. Luckily, oral antibiotics are available. So the infectious disease specialist started the patient on teicoplanin and then shifted to oral clindamycin and rifampicin. The antibiotics were continued for a total of 6 weeks. What must be remembered regarding the use of rifampicin as far as Staphylococcus is concerned is, it's a very good antibiotic against the biofilm, but it should never be started in the first 10 to 14 days. It should be started only after the wound is dry, and it should be started as a combination therapy, never as a single drug regime. The reason being, if we start the antibiotic rifampicin therapy early or as a single drug, the bacteria develop resistance within no time. And this is a very important drug, especially in the Indian scenario where we see a lot of tuberculosis cases. So we do not want development of rifampicin. but it's a good drug. We should know where to use it, how to use it in staphylococcal infections. So in this case, we could retain the implant because the duration was early. It was just 10 days since the primary surgery. Fixation was stable. We had an oral antibiotic available at our disposal, and we could achieve soft tissue cover. We observed the patient clinically and radiologically. The fracture consolidated at 6 months, and we had an infection-free follow-up at 14 months. So all these three cases that I've highlighted so far show that when all these criteria are met, we can retain the implant, and there's a good chance that the fracture will consolidate. But how often do we see these situations? There is always one or some other criteria which is not met, or maybe two or three. What do we do in those situations? Do we always have to follow these guidelines? What we must remember is these are guidelines. They're there to guide us. At the end of the day, we need to assess each patient as an individual and then take a decision. Like in this case, it was a 69-year-old female who had a subtrochanteric fracture of the left femur. The primary surgeon did a long cephalomedullary nailing. Unfortunately, the patient developed a local collection along the proximal thigh with warmth and tenderness. Again, the hematoma was aspirated. Here, the culture group Proteus vulgaris, which is a gram-negative bacteria, and was a highly resistant organism, resistant to even meropenem. So the only antibiotics available were colistin or fosfomycin or tigecycline, where no oral options are available. So then the patient presented to us at around 6 weeks since the primary surgery with a persistent collection, warmth, pain on movement. The patient was on meropenem. This was the X-ray at presentation. Now, when we look at the guidelines, the duration of infection was around 6 weeks, which was beyond what these guidelines recommend that it should be within 4 weeks. The fixation stability was questionable. The helical blade was a little proximal. The tip apex distance wasn't ideal. The fracture seemed to be in a varus configuration. The bacteria was highly resistant with no oral options. The only thing that we presumed that we could do was achieve a primary soft tissue cover because, as I said, thigh is a lax tissue, where primary closure can be achieved in spite of aggressive debridement. When we look at this X-ray, what helped us in our decision making was the medial wall was collapsed and there was continuity there. There was no fragmentation or combination there. So we decided, as per our protocol, to go in, excise the entire scar. What needs to be seen here or noticed here is whenever we do a cephalomedullary nail, there is an incision for the entry point and there is a second incision slightly distal for the helical blade. So these are minimal invasive procedures. But there is no minimal invasive surgery as far as infection is concerned. Because deep inside, the bacteria do not follow any minimal invasive pattern. They spread along all the tissue planes from superficial to deep. So what we need to do is excise the entire intervening normal tissue as well, along with the previous scars. So we went in, we excised the skin, subcutaneous tissue, IT band, vastus lateralis, muscle, and mass as one big piece till we got healthy bleeding tissue. We realized that there was infection along the helical blade entry point as well as the nail entry point. Both these areas were debrided with scoops. We took the C-arm and ensured that we could reach all the areas around the helical blade, scraped off whatever we could. We sent multiple deep tissue samples, labeling each sample separately. And since we already had a culture available because of the previous aspiration, we used stimulant beads, mixed them with colistin and put them inside the wound. So, which would enable us to get local antibiotic as well as systemic antibiotic. Because whenever a patient is on meropenem or colistin, they do tend to develop a lot of systemic side effects. So the local antibiotics can help us just in case systemic antibiotics cannot be given because they achieve very high MIC values locally. So going back to this X-ray and the patient and how we can go forward, whether we can retain the implant or not, the duration of infection could not be modified. It was at 6 weeks. It was beyond what the guidelines said. The fixation was stable because we realized that intraoperatively as well that there was no movement there. It was a stable fixation. The nail was stable. The fracture site was stable. The bacteria was bad. It was a drug-resistant one, but we could achieve soft tissue closure. So 2 out of the 4 criteria were met. What we decided was we can observe this patient. We sent serial ESR CRPs which gradually decreased. At 3 months, they were normal. The wound was dry. Clinically, the patient had no issues at all. Again, at 5 months, the X-ray showed signs of consolidation. ESR and CRP were persistently normal. Wound was dry, and the fracture consolidated at 7 months. Patient has followed up to 10 months and has an absolutely infection-free uh, uh, clinical status. The scar is healed. The patient can do an active SLR walk using a walking stick. And the patient is comfortable. A similar case with the distal, sorry, this case highlights that in spite of not all criteria being met, we can try and retain the implant provided the construct is stable. That is the most important criteria for retaining any implant. Highlighting a similar scenario where a patient had a trimanular fracture subluxation. The patient was 66-year-old with diabetic, poor soft tissue condition along the medial aspect. We fixed the posterior and lateral malleolus first, delayed the medial wiring, went in at around 10 days and fixed the medial malleolus with a tension band wiring. The skin condition was very questionable. There was very high chance of wound breakdown. As suspected, the wound did break down at 8 weeks and the medial wires were exposed. Now, this is a big dilemma. The wire is exposed, you can actually see it. The subcutaneous implant, there is no soft tissue there. But what we realized that the patient was absolutely asymptomatic. The fixation was stable clinically and radiologically. There was no discharge, no wound. CR were not. What we decided in this case is we'll just observe the patient. We just covered the exposed wires with sterile dressing. Did not start the patient on empirical antibiotics. That is important because in case the patient develops an infection or started getting discharge or redness, we would have had to go in and debride and get deep tissue samples, which would hopefully give us what bacteria was the causative organism. If the patient was on empirical antibiotics, the chances of getting a culture positivity would have been very low, and the chances of success would have again gone down. A positive culture is something that really helps us give targeted antibiotics rather than just putting the patient on empirical antibiotics. And in today's scenario with highly resistant organisms, we don't know whether the empirical antibiotic is going to help us or not. So like I said, we observed this patient and thankfully the fracture went on to heal. There were no local issues. Once the fracture consolidated, we removed the medial wires. The patient had an infection-free follow-up of around 1.5 to 2 years after the primary surgery. The medial soft tissue healed completely. So as trauma surgeons, we must remember that we have a very small window period, possibly of only up to 4 weeks where we can go in, debride and try and retain the implant. But we can be flexible, provided our construct is stable. The fixation is stable, the entire construct is not loose, there is no movement at the fracture site, implants are not backing out. Then we can go in, debride aggressively as much as we can, not worry about the closure, because if we cannot achieve primary closure, we can involve the plastic surgeon and achieve early soft tissue closure. Because we need to start thinking as a team whenever we deal with bone infection, not as an individual. We can do a fracture fixation individually, but when we deal with infections, we must involve the infectious disease specialist or a physician to understand the bacteria, to understand what antibiotics must be started and at what dosage. The plastic surgeon obviously helps us close the wound as early as possible, and we need to assess every case on its own merit. Having said that, the story does not end here, because there are some cases where an early surgical site infection is dealt with, the fracture consolidates, but the infection may still persist. To highlight this scenario, I want to show this case who had a distal femur fracture fixed with a lateral distal femur locking plate. Unfortunately, the patient had an early surgical site infection. The primary surgeon debrided the wound. The culture grew methicillin sensitive Staphylococcus aureus. Patient was started on Reflin, which is cefazolin, and oral clindamycin for 6 to 8 weeks. The wound was observed, the X-rays were observed, the fracture went on to consolidate at 9 months with no signs of infection. Patient was then followed up serially and had no issues at all. At 2 years from the primary surgery, the patient came back with knee effusion, restricted knee range of movement, tenderness along the distal femur, collection, redness, warmth. A Mars MRI was done. What the radiologist suggested was there was a collection along the distal femur with an effusion in the knee, and there were abnormal signals around the implant in the distal femur suggesting that there was an osteomyelitis of the distal femur. We went in, excised the previous scar, removed the implant, and as soon as we removed the implant, we found a thick layer of biofilm covering the entire lateral cortex of the femur. We excised that biofilm and started scraping the distal femur, and as we started scraping, all the screw holes started becoming one, coalesced into one big cavity in the lateral condyle, which showed us that the entire cancellous bone was grossly infected. But the fracture site had healed. There was no movement at the fracture site, which was surprising that in spite of such florid infection, the fracture still went on to heal because the primary fixation was very, very stable. The culture grew the same bacteria, MSSA, which had grown in the first debridement 2 years back, which showed that the bacteria, although you debride it in the presence of an implant, your fracture may consolidate, but the bacteria may still persist within the bone, and it can come back with a recurrence of infection somewhere later because foreign body is still there. The plate was still in situ. We put in local calcium sulfate stimulant beads with cefuroxime in this case, and the infection went on to subside, and the patient had a good follow-up at 1 year after the debridement. What we must think in surgical site infections, and what this case has highlighted, is that after the fracture consolidates, we must consider early implant removal, because this implant, as I said, is a foreign body at the end of the day. In spite of fracture consolidation, the infection can always come back. So to summarize my talk, the first thing that we need to identify as surgeons is to identify a leaking wound. A leaking wound is normally a deep infection. Very rarely is it just a stitch abscess. Very rarely it is just a superficial wound. Bacteria do not understand planes. What we consider a superficial wound can actually be a deep wound. Unless we explore, we will never know that. So we have a short window period, 4 weeks, 6 weeks, where we can go in, debride radically before a mature biofilm forms around the fracture site. Because once a biofilm forms at the fracture site, the chances of that fracture going on to heal are very, very less. So we need to go in and remove that biofilm and remove all necrotic tissue as soon as possible. The next part that we need to assess is the stability of the construct. If the construct is unstable at the time of our debridement, we may add a cerclage wire or an extra screw or an extra plate to add stability to the construct. Because what we want in these cases is fracture healing under the cover of antibiotics. And then we can consider removing the implant. So to assess, to ensure that the fracture consolidates, we must debride radically. Once we debride it radically, we at times need the help of plastic surgeons to cover the wound early so that the plate is covered with a thick flap. Or primarily, having debrided the wound and got deep tissue cultures, the culture pattern must then be assessed by the infectious disease specialist, and the patient must be started on targeted systemic with or without local antibiotics based on our decision. The patient then must be monitored serially based on the clinical signs, radiological monitoring of the X-rays, and serological monitoring of ESR and CRP. There has to be a downward trend with time, and eventually the ESR and CRP should normalize. After the fracture is consolidated, we must consider implant removal once we are sure that the bone is strong enough to withstand implant removal. So what this talk shows us is that fracture fixation can be done by us orthopedic surgeons alone. But the minute we start dealing with infections, we must involve our colleagues, have a team manages this case involving plastic surgeons, radiologists, microbiologists, pathologists, infectious disease specialists, because it's only a team which will help us ensure a good outcome for our patients. Thank you.
Thank you very much, Aditya. That was a comprehensive talk and very, very stepwise approach to dealing with orthopedic infections with implant in situ. Thank you very much, and I hope we continue this orthopedic infection week in this entire month and have more insights into orthopedic infections.
Thank you.
Thank you very much, Aditya.
Thank you.